Thanks everyone for having me. I know we were going to give this update a little sooner in September and then thought we'd hold out and see if there was sort of more guidance that's emerged in terms of vaccines. And I think there has been. So hopefully I can round out where things are right now for the fall as we head into the fall winter season. So hopefully everyone can see and hear. And I'm going to launch in. So our objectives today, we're hoping to review the epidemiology of the common respiratory viral infections for which we have readily available vaccines. That's RSV, COVID, and flu. I'm going to provide some updates on the current recommendations regarding vaccination for each of these and discuss some of the events related to COVID vaccination. Of course, it's been a little bit bumpy this fall, but just sort of let everyone know where things stand and what guidance has emerged and sort of what the different messages are that we can look to. So we'll start with the case and we'll use this just as context for the discussion. So a 66-year-old man, I think common scenario, is presenting for follow-up care. He has a history of diabetes, COPD. He's on a GLP-1A and has well-controlled hypertension. He received the initial COVID vaccine series, so that goes back now several years, but has declined further doses, and received the flu shot last fall in October of 24. He's never received a vaccine for RSV, but has seen some commercials about this and asked, Doc, which vaccines do you think I should get this fall? So we'll start with RSV. There have been some updates to the recommendations, and RSV is kind of the newest vaccine that we have available, made available in 2023. So I think interesting just to sort of go through that data a bit. I think it's one that there's still relatively limited uptake, and I think still a lot of questions from our older patients. So as general background, most RSV disease does occur among older adults. We know that about 110 to 180,000 adults over 50 are hospitalized in the US each year. So significant burden of morbidity and mortality as well, with about 6 to 10,000 deaths a year, particularly among those 65 and older. And we know, as with all of the respiratory viruses, that certain medical conditions do place patients at increased risk for more severe disease. These are relatively intuitive, but things like chronic heart disease or lung disease, frailty, and really advanced age. And severe disease can occur as well, not unexpectedly in patients who are immunocompromised. We're not going to talk so much about babies here today, but it is also a common cause of acute lower respiratory tract illness and a leading cause of death in very young infants, so less than 6 months. And there has been now, new tools in terms of prevention of RSV in that group, which I'll mention briefly. So the recommendations around RSV vaccines sort of begin in 2023. The season of 23 to 24 was the first season that we had RSV vaccine available and recommended. And at that point, the initial recommendation from the CDC was that it was for adults 60 and older through shared clinical decision making. And we'll talk a little bit about what that means. I think it's relevant now with COVID as well. I mean, I guess I would argue that any vaccination decision with the patient is always shared clinical decision making. I mean, nothing at this point is mandatory, right? I mean, we want to come to a shared decision with patients about most things in their healthcare. So I don't think at face value there's anything sort of wrong with that term, but as a vaccine recommendation, it can be confusing. It leads to some issues in terms of coverage. And I think patients and providers, frankly, don't always understand how strong a recommendation shared clinical decision making is. So that was sort of where things stood initially. And in June of 24, so last year, the CDC made a stronger recommendation. And they said, based on sort of accumulating post-licensure data, they ultimately said, really, we recommend RSV vaccine for all adults 75 and older, and for adults who are 60 to 74 at increased risk of severe RSV. And again, that was a shift away from the shared decision making and some of the implementation barriers that can be associated with that. Additionally, they made recommendations for infants. So the RSV vaccine is recommended in pregnancy at 32 to 36 weeks of gestation, specifically with Abrysvo. So only one of the 3 RSV vaccines can be given to pregnant patients, or babies can get a monoclonal antibody after birth for RSV prevention. And finally, RSV vaccine is not at this point an annual vaccine, so the recommendation was, for a one-time dose. And then what happened this year? So not a huge change, but I think it was a little bit under the radar over the summer. The age range was expanded and dropped to age 50. So at this point, heading into this fall and winter, the recommendation is still a single dose of any FDA licensed RSV vaccine. Again, strongest recommendation for adults 75 and over, but also for adults 50 to 74 who are at increased risk of severe RSV. Um, there are three RSV vaccines that are available for adults. Usually, we don't have a lot of control over which is being given because most patients are going to get this at the pharmacy, and I'll talk a little bit about that. But we have GlaxoSmithKline's Arexvy, Pfizer's Abrysvo, and the Moderna Mresvia, which are all FDA approved and available. And there's no recommendation from the CDC or ACIP about which patients should get. Um, Really, since it's a one-time dose, patients can get it at any time, but the recommendation would be if they've never had it to get it in the late summer or early fall before the RSV season gets started. And again, not at this point an annual vaccine. Clinically, I think RSV, most of these respiratory viruses are indistinguishable from each other clinically. Patients often have mild symptoms, maybe nothing at all, but if they have symptoms, usually that's like a URI. And unfortunately, sometimes can be more severe, and we can see exacerbations of whatever underlying health issues patients have, like COPD exacerbations or heart failure exacerbations. And that's where the real morbidity can come into play. This is a big list of conditions that we think increase risk for severe RSV, and we don't need to go through it one by one, but I think, clearly I worry mostly about patients with chronic lung disease. We do tend to see patients who are hospitalized and very sick from respiratory viruses with chronic lung disease, but also patients with chronic cardiac issues, immunocompromised patients, patients who have issues with airway clearance, so neuromuscular issues or severe frailty. Those are some of the major risk factors. In terms of the burden from last season, so again, the RSV vaccine is now available, but uptake has been relatively slow, and so there's still a significant burden of disease related to RSV, millions of visits last year, and still, hospitalizations in the hundreds of thousands range, with 10 to 20,000 estimated deaths last year related to RSV. And this is really just a sense of what happened last year overall, which I think is helpful, again, because the landscape has changed year to year, particularly in the past 5 years post-COVID, just sort of to get a sense of what's been going on, and we'll see what this year brings. But the dark blue is last year, 24 to 25, combined COVID, flu, RSV. So similar to the year before and still pretty significant burden, slightly later, but again, a peak around February. And then actually what you can see, the biggest contributor was the light blue, which was flu. So last year, we'll talk about this, but was a bad flu year. And that's important just to keep in mind. The flu hasn't gone away. We saw a lot of flu last year, including flu deaths, including flu pediatric deaths. And then we have COVID and RSV, which were down here, which were, not as significant, but still, of course, plenty of cases. So I mentioned that there are three available RSV vaccines, Arexvy, which is the adjuvanted GSK vaccine, Abrysvo, which was made by Pfizer and is the only vaccine for RSV approved in pregnancy, and Mresvia, which is the newest, came out a year later in 2024 and is an mRNA vaccine. I don't want to go into too much detail, but I thought it would be helpful just to briefly review the vaccine efficacy of the RSV vaccines again, since these are still relatively recent, and to look at sort of what the trial data has showed us and then what's happened in the real world over the past couple of years. And I think the bottom line is that the vaccines work quite well at preventing illness related to RSV, including hospitalizations. So you can see, I'll move this bar down a little bit. But from the original trials with Arexvy, we learned that efficacy was quite high in the first season, 80% range at preventing RSV-associated lower respiratory tract disease. That held up in the second season, though there was quite a bit of waning, and I think we'll find out in the years to come what the recommendation is around subsequent doses. And then in the real world, importantly, we saw that this really did hold up in this first season that the vaccine was available. The Arexvy vaccine was, 77% effective in preventing ED encounters and 83% in RSV-associated hospitalization. So quite effective in the real world. Pfizer as well. sort of similar numbers, but season one, quite efficacious, 85% efficacy. Season two, again, it held up very well, 78%. And in the real world, again, 70 to 80% efficacy in preventing ED encounters and hospitalizations. So those are, impressive numbers in terms of how well the vaccines worked in the real world. And then the newest member of the team I mentioned was the mRESVIA, which is the Moderna mRNA. So we have less real world data, but some data from the trial, which led to its approval. And again, showing vaccine efficacy is sort of in the 78, 80% range at preventing RSV-associated lower respiratory tract disease. As time went on, this did fade. I think we're going to see that with everything. We see that, of course, with COVID and with flu vaccine. Um, into the second season at the 18-month analysis, again, that efficacy was down to the 50% range. So we'll find out what recommendations in the future there are about subsequent doses. But for now, that's been considered kind of adequate. Um, and importantly, we'll talk about the safety a little bit, but there was a low rate of adverse events seen with the mRESVIA and no safety concern with Guillain-Barré, which had come up with both Arexvy and Arisvo. And I'll talk about that in a minute. So this year, I mentioned that the ACIP did expand the age range to adults 50 to 59 who are at increased risk for RSV. This was FDA approved last year, actually, for that age group, and the CDC in July did accept that recommendation and expand the age criteria. I think that's kind of most useful. 50 to 59-year-olds can be quite variable in terms of health status, but certainly our patients, I have some patients who have really significant pulmonary disease, significant comorbidities, or immunocompromised patients. These are patients who we might really want to target, and it wasn't available to them before. There's some ongoing discussion about even younger adults, but the ACIP has so far found that there's insufficient data in a group 49 years and younger to inform RSV vaccination. So no recommendation for anyone younger than 50 at this point. So what about safety? I'm not sure if folks have had any of these conversations with patients, but I do think that the Guillain-Barré question is a bit challenging because that data is out there and it does seem to be an actual signal related to Guillain-Barré. So in the initial trials, they noted in both Arexvy and Abrysvo that there were some cases, handful of cases of inflammatory neurologic events, and that included Guillain-Barré that occurred after vaccination. And as time has gone on, we've sort of got some accumulating data. Last year, they had put this out estimating what we can anticipate from impact on hospitalizations versus number of vaccine attributable Guillain-Barré cases. And again, sort of saw the greatest benefit in terms of impact on hospitalizations is in our oldest patients, over 75. So we could estimate, maybe the significant increase on prevented hospitalizations with Arexvy and Abrysvo, but a small number in relation of estimated Guillain-Barré that can be attributed to the vaccine. And ultimately, in January 2025, the FDA did require that a Guillain-Barré syndrome warning be included in prescribing information for Abrysvo and Arexvy. And most recently, this is the last study I'll mention, but there was a big study recently published on real-world data, RSV vaccine, patients 60 and older from that first season, looking at patients median age 74, so mostly older patients. And again, I would say a couple major points, the vaccine efficacy did hold up. So again, 75% efficacy. This study had, many, many patients. It was like a large electronic health record database. They had about 31% of the cases were immunocompromised. So that's helpful because we hadn't seen before a lot of data on immunocompromised patients, and the vaccine efficacy was fairly robust in that group as well. But they did continue to see this small number, but excess number of Guillain-Barré cases, about 5 per 1 million doses of vaccine given for Arexvy, and about 18 per 1 million doses of vaccine given for Abrysvo. Just move this out of the way. So this is just showing you sort of vaccine efficacy. And in the immunocompromised patients, if you take transplant patients, kind of all comers, vaccine efficacy is lower, but still in the 50 to 60% range. I think that was helpful data for our immunocompromised patients. The lowest efficacy was seen in the stem cell transplants, in whom the efficacy was quite a bit lower. And that's not surprising, but important to know. So where do things stand with the safety assessment? I think this is currently what the ACIP and CDC basically says. They say that in the trials, there were a small number of participants who developed serious neurologic conditions, including Guillain-Barré. For both vaccines, kind of put together, the FDA estimates the risk to be about 10 excess cases per 1 million older adults vaccinated. There have been no reports related to mRESVIA from the trials, and I think that real world data will have to accumulate with time since it's newer. And there will be vaccine safety monitoring, of course, that will continue for these vaccines and for Guillain-Barré that's potentially caused by vaccines. But they continue to conclude that based on the available data, the benefits outweigh the risks, particularly in patients who are 75 and older and in those who are at increased risk for severe disease, 50 to 74. I think this leaves a few sort of just ongoing questions and obstacles with RSV. So clearly it seems to work well at preventing hospitalization. I think we're still going to learn what the role is for repeat vaccination, but the current recommendations for a single dose. Coverage remains very tricky. It's through Medicare Part D, which means it's given at the pharmacy. And I know at least for us, while many patients nationwide do get vaccinated at the pharmacy, a lot of our patients prefer to be vaccinated on site in the office. It's just easier. It's an access point. It's where they're getting flu and COVID often. So that can be a bit of a hurdle. I mentioned the Guillain-Barré, so there will need to be ongoing surveillance for safety events. And then it is okay to give with other vaccines. I know that's a question that comes up frequently. So COVID. So I spent some time talking about COVID. I know that's highly relevant and has been a bit confusing this year. So hopefully we can sort of clarify again where things stand. So first, just in terms of the epidemiology, it's remarkable to see where we were and where we're at. So luckily, things have improved greatly from the early seasons of 2021 and the Omicron surge that happened. And we've seen cases, peter out, though not disappear. And that's where we stand sort of heading into the 2025 winter. Death rates similarly, right? So luckily, we've come a long way from these huge peaks of the death rates in 2021, 2022, and we're now at a point where death rates are much lower, though unfortunately still occur. And I know this question came up recently about, cumulative deaths in the US from COVID and whether we know that number, and we do. It's readily available, and we know that about 1.2 million people in the US have died of COVID. So important that we keep that in mind and try to do our best to prevent severe disease. In terms of ongoing data, the CDC does continue to track. I think sometimes it's unclear like what tracking is still happening and how much people are testing and what's available to us to know, where things stand. But there is ongoing data that helps us understand if we're in a wave or heading into a wave. And the CDC looks at test positivity. They look at ED visits that were diagnosed as COVID. And you can see that, there was the wave of the winter, which wasn't terrible last winter, December sort of into February. And then there was the summer wave again this year as we sort of continue to see. And again, we're coming out of, but, there often is that summer wave that occurs. So in terms of vaccine recommendations, I think it's a little bit helpful to sort of take a step back and think about where we were last year. Because last year things were maybe a bit more straightforward. I think it's just helpful context to think about what data might have changed since last year. In fact, it hasn't really, and sort of what recommendations were made last year in a different climate and what recommendations have been made this year in a kind of chaotic federal climate. So last year in June, the ACIP recommended COVID vaccine for everybody 6 months and older. They made a universal recommendation similar to the flu vaccine recommendation. And I had listened at that point to the full ACIP meeting and discussion. It was actually pretty informative and helpful to understand how they came to that conclusion. In August, ultimately, the FDA approved the vaccines for last year, which were targeted to the strain that was circulating at the time from Moderna and Pfizer in use for patients over 12. And then for younger patients, the vaccine was authorized under emergency use authorization. And additionally, they authorized Novavax, which is the non-mRNA vaccine that's available, as you're all probably aware. And why did they make that universal recommendation? So partly because, just fundamentally, and I think this helps for counseling with folks, SARS-CoV-2 continues to evolve. And I think we're familiar with that as we are with flu, right? The flu virus changes from year to year. We know COVID does as well. And the vaccine is adapted so that it keeps up with that evolution and is as effective as it can be each fall. Also, COVID-19 vaccine effectiveness wanes. As you can see, all of these vaccines do, right? For the most part, effectiveness doesn't hold up. And so, a vaccine that patients say, like, I got a vaccine, in 21, 22, I already got four. We don't count them anymore, just like we don't count flu vaccines anymore. We know that they fade over time, and we want to be as protected as we can be heading into the season of when we think there's going to be the most COVID around. And then, despite all of that progress that we've seen with hospitalizations and with deaths, with volume, there are still, unfortunately, hospitalizations and deaths that are associated with COVID. And so it is a vaccine preventable disease. Um, those numbers are highest for our oldest patients, which I think makes sense, right? Our most vulnerable population, followed by the very young. In 2023, there were still about 45,000 COVID-associated deaths in older patients over 65. And in 2024, though, numbers improved, COVID was still a factor in about 47,000 deaths in the US. So ultimately, last year, again, it was a universal recommendation, really because it was felt that there's vaccine preventable morbidity and mortality in all age groups. Because the vaccine is effective, we have tremendous safety data now, billions of people have received this vaccine. And because a universal message is straightforward and it allows for equitable access. And I think we've already seen this year what it looks like when the messaging is not straightforward, right? And access is really uneven. It varies from state to state. Patients can't always get it when they're looking for it, even when they might be at higher risk, and would benefit the most. This is just a look at the efficacy fading or waning over time. This comes from ACIP last fall, but I thought it was just a helpful sort of image of what can happen over time. So the maroon kind of brick color is the 2023 to 24 vaccine, the last year for which they had data. And you can see that efficacy against hospitalization was lower than against critical illness. Efficacy against critical illness was sort of up here, above 60%, and did fade over time, though some persisted. And efficacy against hospitalization was a bit lower in the sort of 45%, 50% range, and really faded by 180 days to sort of negligible. So again, just sort of showing us there's some persistence of the efficacy, particularly against critical illness, but we know that the vaccine does fade or wane. So where are we at this year? So just to recap, sort of a number of events from the last 2 months or so. In August, the FDA approved the COVID vaccines, but with a narrower label. So this time, Pfizer's vaccine for COVID, Comirnaty, which I find kind of hard to say, I don't think is very great marketing term, was approved for individuals 65 and older, or 5 to 64, but if they're 5 to 64, only with an underlying condition that puts them at high risk for severe COVID-19. Similarly with Moderna, so there was Spikevax, which we've had for some time, approved for those 65 and older or 6 months through 64 at high risk. And then mNEX Spike is a newer Moderna formulation that can be given at a smaller dose. This was approved for over 65 or 12 through 64 at high risk. And finally, Novavax was approved over 65 or 12 through 64 at high risk. And there were a lot of questions about gaps in this. Where does that leave healthcare workers? Where does that leave small children, young children who have never been COVID vaccinated before? Where does that leave pregnant patients? It was unclear which list was high risk, what we were referring to, where some folks fell in this paradigm. But the interpretation was that any use other than what's outlined here would be considered off-label. Pfizer did provide a number of webinars, actually, which were helpful in September about the vaccine. And, I would say not controversially, their stance is that about 3/4 of adults in the US are at high risk for severe illness from COVID. It depends, again, what the risk factors are that we're taking into consideration. I would say all risk factors aren't created equal. But the CDC's list, which hadn't been updated at that point, still listed things like pregnancy as a risk factor, which we know sort of science has established as a risk factor for severe illness, physical inactivity, chronic lung disease, immunocompromised conditions, et cetera. So long list. And if you take that into account, then really the majority of adults in the US are at risk for severe illness on some level. And so what did the professional societies end up saying? I think this was another important point. So the AAP, or American Academy of Pediatrics, said in August that their guidance, sort of differing from the label, was that all infants 6 months through 23 months of age should receive COVID vaccine if no contraindications. And really their stance was that babies should meet the vaccine first and not the virus first. Children and adolescents who are 2 through 18 should also be vaccinated if they're at high risk for severe COVID-19, which everyone agrees on that, but also if they're a resident of a long-term care facility or have never been vaccinated or have household contacts who are at high risk, or if their parent or guardian wants them to be vaccinated. So this was sort of quite different, but a firm, clear recommendation. And ACOG, which is the American College of Obstetricians and Gynecologists, came out and said that, despite confusion around pregnancy recommendations in the spring, Health and Human Services had said that they were removing pregnancy from the COVID vaccine schedule. ACOG came out and said, we continue to recommend that patients who are pregnant receive an updated COVID-19 vaccine at any point during pregnancy, when planning to become pregnant, in the postpartum period, or when lactating. There are a couple of additional resources out there that I think have been helpful in this period. There's something now called the Vaccine Integrity Project, which comes from the University of Minnesota's Center for Infectious Disease Research and Policy. They gave a presentation in August where they had experts from the field review all of the data that's been published that they could locate from last August, when the last ACIP meeting was, to this year. Sort of trying to fill that gap, since the ACIP meeting was delayed and it wasn't clear whether it was going to happen and how useful it was going to turn out to be. They reviewed almost 600 studies and had a public meeting. I attended. You could attend and listen to the discussion, which was great. Some members of the media were there as well to ask them questions, and described that there were really no new safety concerns related to COVID-19 vaccines. I think this is helpful to counsel and helpful to understand that nothing has changed in terms of the science from last year to this year. So if last year's recommendation was universal, this year's recommendation is not, and trying to understand where those differences may have come from. Are they rooted in science? It doesn't seem like they are. The IDSA, another professional society that we turn to, is working with other medical societies to formulate guidance, particularly around immunocompromised patients. And that has not been made available yet, but hopefully will be soon. And then the state. So you've all probably heard that the state in New York also has taken actions. I think these have mostly been helpful and clarifying for us, though, again, like, confusing to hear so many different messages all of the time. So in early September, Governor Hochul signed an executive order declaring a 30-day statewide emergency, and that she was expanding who can prescribe and administer COVID vaccines. And so this executive order allowed physicians, nurse practitioners to issue both patient-specific and non-patient specific orders to pharmacists for patients as young as 3. It expanded the pharmacist's authority to administer vaccine, and permitted them really to prescribe the vaccine themselves. So this really gave, I think in that moment in early September, there was a lot of confusion about what patients could do at the pharmacy, whether they needed prescriptions from a physician sent to the pharmacy. And so this did help empower the pharmacists. And then on September 18th, New York State announced that we were joining what's called the Northeast Public Health Collaborative. And this was a consortium of states and public health departments, including the city Department of Health as well, that put out guidance around COVID vaccines. And we've seen this now from various states around the country. But I think, again, another source and helpful for the departments of health to step in where there's been a bit of a gap in guidance. So this guidance is there, and it kind of aligns with the professional societies. It aligns with the AAP for children. It says that all children 6 to 23 months should be vaccinated. It says that children's 2 to 18 years old should be with that list that the AAP had put forward. And then for adults, it said, look, we recommend the vaccine for all adults. We really feel, it should be vaccinated are these groups: those with risk factors for severe COVID-19, those at higher risk of exposure, and that includes healthcare workers, and household contacts at high risk of severe disease. Recommended sort of non-controversially for adults 65 and older, and for pregnant persons. And they put out a list of the populations that they recommend vaccination for in a table form as well. And you can reference these. So I think, again, just trying to simplify guidance and streamline it in a moment where it was a bit confusing who should be getting the vaccine. And then finally, later in September, the ACIP did end up meeting, and then the conclusion at the end of the ACIP meeting was that COVID vaccine was recommended for anyone 6 months and older after consultation with a healthcare provider. So basically, shared decision making was the ACIP recommendation, though this was still pending adoption from the CDC director. I'm not sure to what extent this kind of changes the landscape. I think that the recommendations from the state, from the Northeast Public Health Collaborative, were honestly more clear and directive than this ultimately was. And I mentioned earlier that shared decision making, like while of course vaccine conversation should be happening and should be always a shared decision as a recommendation, I think honestly this didn't really help us much one way or the other. I think the bottom line is to understand that, the science has not fundamentally changed, that there are certain risk groups that are clearly at highest risk of severe disease, those with underlying comorbidities, those who are older, those who are pregnant, those who are young and have not yet been vaccinated. And then there are folks who are at high risk for contact with others who are at high risk, and those groups should also be vaccinated so that they are not responsible for making someone sick who could get very ill. So what ongoing barriers and questions do we face? I think we have more information than we did earlier this month, but I think it's still unfortunately a chaotic way to handle public health. So there's been discordant messaging with recommendations from professional societies, as I outlined, that are different from the FDA label. Um, there's been some like a bit of a lack of clarity on what constitutes high risk, though I would recommend that folks use that Northeast Public Health Collaborative and the state guidance. I think they did a good job of really clarifying who is at high risk. Um, there's variable comfort with what off-label prescribing looks like. I think most of us who treat adults feel fairly comfortable prescribing off-label. Lots of things we do are in fact off-label. Um, but that's just an understandable hiccup in this process. There remain some barriers to access and confusions about how to access vaccine. I think the more we make vaccines available, the better. In our clinic, we advocate to have COVID vaccine on site. We have for years now. I think it makes a huge difference for patients not to have to go to multiple different places to get vaccine, and to trust the source that they're getting it from. And so I think, again, the easier we can make it for patients, the better. I mentioned the ACIP recommendations. I think they were not particularly strong, and they were delayed, and they are still pending adoption. So I think that remains an issue this year. And then we have the state level executive orders, which I think here in New York were quite helpful, but this is variable from state to state. And so outside of New York, that's still a gap. And this is what we've seen in the lay press, right? So I think it's just been it's been confusing and hectic, and we've seen lots of different stances, and just sort of that reflection in the press of what people are feeling in the general population. I just want to very briefly mention PEMGARDA. It's probably not relevant for most of the patients you all see, but just to know that we still do offer this. It's a monoclonal antibody. It's really meant for patients who are moderate to severely immunocompromised, who we think won't respond effectively to the vaccine or as effectively. And so we offer this as another tool to prevent COVID, really severe disease. It's done through ID. So we do an outpatient ID evaluation. Patients who are eligible are those who are, again, more immunocompromised. So for example, receiving a B cell depleting therapy like rituximab, or transplant recipients, particularly lung or stem cell, or a primary immunodeficiency. We can do a visit with one of our ID faculty, and they can connect patients to the PEMGARDA infusion. Okay, and that's COVID. Flu, luckily, is our most straightforward. So we'll go through flu relatively quickly. But just a brief word about epidemiology and last season. So, as we all know, and this has not changed, flu continues to cause annual epidemics, typically in the US in the fall and the winter, tends to peak in December to March. We think usually starting around October, though this can vary from year to year. And the best time we think to get vaccinated is generally around October. Um, Flu is associated, unfortunately, with still, hundreds of thousands of hospitalizations each year and tens of thousands of deaths, and particularly at times pediatric deaths as well. The risk of hospitalization, as we've said throughout for these respiratory viruses, highest in our older adults. And this is just showing you last year. So again, last year was the worst flu season we've seen in over a decade. And so we should sort of take note and continue to be mindful of that. And I think, a major reason for that probably was lower vaccination coverage. There might be some flu-related factors or viral factors, but it seems like the severe disease indicators were kind of similar to prior years, but there was just more flu last year. There were just more cases. So more cases meant more severe cases as well. Um, and according to the CDC, pretty large estimates of disease burden. So millions of flu illnesses and medical visits, 600,000 to 1.3 million hospitalizations, and a number of flu deaths last year, probably in the 30 to 130,000 range. Um, so again, this is a vaccine preventable morbidity mortality. Who's at risk for influenza-related complications? I think we know this, and we've seen these similar lists for the other viruses. But again, children at the very young age of the spectrum, adults who are 50 and older, those who are immunocompromised or chronic conditions, etc. What is the recommendation this year? So luckily, recommendations this year for flu are really about the same. The flu vaccine is trivalent, again, covering 2 influenza A strains and 1 influenza B strain. Routine influenza vaccination is recommended this year universally, as in the past, since 2010, for everyone 6 months and older who does not have a contraindication. Ideally, again, that timing is September, October. We don't generally recommend giving it in the summer, though it starts to come out in the pharmacies, but it's really most efficacious a little bit later because, like all these other vaccines, it can fade over time. Um, the ACIP does continue to recommend that older adults 65 and over receive a higher dose or adjuvanted flu vaccine. There's data to support increased efficacy in that population. And more recently, last year, the recommendation changed for patients who have a history of solid organ transplant, that they also can receive high dose or adjuvanted for better efficacy in this population. We did just at Sinai throughout the health system change our EPIC order sets last year. So you might notice this prompt if you're in the EPIC system to asking if the patient has a history of solid organ transplant, really encouraging those patients to get a higher dose. This is our comparison chart that we put out every year. So again, just the basics, standard dose or high dose or adjuvant is available. Who should get the high dose or adjuvant is generally older patients or solid organ transplant recipients. We talked about when flu activity generally peaks kind of mid to late winter, and the flu vaccines are safe. Patients sometimes worry that they can get the flu from the vaccine. I'd say it can make you feel crappy for a day or so. That's not unexpected, but it's not going to give you the actual flu. So coming back to our case, our patient received, we said, the initial COVID vaccine series last year, or sorry, several years ago, but had declined further doses. So we're going to go ahead and recommend this year's updated fall COVID vaccine. I don't think this is, a controversial recommendation. This patient is over 65, has risk factors for severe disease, including diabetes on a GLP-1A, hypertension, COPD. So I would make that recommendation, and ultimately the patient can decide. Flu vaccine, similarly, given last year, so would recommend this year's updated flu vaccine. This patient has never been vaccinated against RSV. I would recommend a one-time dose of any of the available RSV vaccines. And in a future visit, would discuss, additional vaccines that are out there, of course, pneumococcal and Shingrix, which are both also recommended for patients in this age group over 50. And finally, just a note, I think we're in a challenging moment in terms of vaccine discussions and vaccine dialogue. I think we've sort of got to think about how to talk about vaccines and how to understand them and understand where patients are coming from. So I think, again, practical issues to me, access, I think are huge. I think many patients, when a vaccine recommendation is made by a provider that they trust and the vaccine is readily available, are actually quite willing and interested in taking them. And again, having that dialogue and having a trusted provider, I think, is also key. And I've probably shown you all this in the past when I've been here to talk, but we do have an app for our ID guidance. We continue to update First Line, so it's great to download if you haven't yet. We keep all of our antibiotic guidance here and other guidelines related to infectious disease syndromes. And that's it. I'll take any questions